Recording in progress. Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. First of all, we like to thanks to God who has given us some mercies and blessings so that we can gather here in Auditorium Tahir Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada. First of all, I would like to greetings to our distinguished guest lecturers from Murdoch Children Research Institute, Australia, Prof. Margie Dunchin and Prof. Julie Bynes. Good morning. And I would like to send greetings to Prof. Yati. Good morning, Prof. To Ibu Meneni as our moderators for today. And eminent professor, lecturers, and participants, good morning and welcome. On behalf of Department of Biostatistics, Epidemiology and Population Health and Center for Child Health, Faculty of Medicine, Public Health and Nursing, Universitas Gadjah Mada, I warmly welcome you to our guest lecture, which is the title, Vaccine Journey and Implementation Issue. Hopefully, this lecture will bring many benefits for all of us. For today's highlight agendas are opening, presentation from Prof. Margie Dunchin with the title, Has the Pandemic Increased Vaccine Hesitancy and Affected Routine Immunization? Presentation from Prof. Julie Bynes with the title, From Discovery to Implementation, the Development Journey of the RV3BB Rotavirus Vaccine, discussion, and then closing. Without further delay, it is now time to our main agenda, the presentation for our guest lecturer. And in this opportunity, I would like to introduce the moderator of the session. She is Dr. Meneni Sitaresmi, PhD, Pediatric Specialist. We have her CV in video, and we would like to give it. Okay. Public Health and Nursing Universitas Gadjah Mada and from Dr. Sarjito Hospital. She graduated as a general practitioner from Faculty of Medicine in 1989, took a pediatric specialty at Faculty of Medicine in 2002, and took PhD at Vrije Universiteit Amsterdam in 2009. She is involved in the Immunization Task Force organization of the Indonesian Pediatrician Association and many other organizations she participates in. To Ibu Meneni, the time is yours. We give applause.
Okay, thank you very much for introducing me. Good morning, Prof. Yati, Prof. Julie, and Prof. Maggie, and also for audience in this room and also in this Zoom meeting, because our lecture is also blended. So not only for Zoom but also YouTube. So after, because we have a faculty member that very busy, so maybe if they cannot join this live, so they can look for the YouTube streaming. Okay, so we know that children morbidity and also mortality in Indonesia are very high, and after neonatal period, some like prematurity, asphyxia. So infectious disease is the most cause of morbidity and also hospitalization in Indonesia. And most of them can be prevented by immunization, such as pneumonia, rotavirus. And we know that the immunization is one of the most effective intervention to prevent some threatening disease, like I mentioned before. In spite of this benefit, we still have to work hard because the coverage is very, it's not reach the target, especially during the COVID-19 pandemic. And some reason is due to vaccine hesitancy, And we know that pandemic COVID has disrupted some essential care, such as immunization and also another essential care. But we maybe we don't know exactly whether this pandemic COVID also influence or increase the vaccine hesitancy. So we will learn from Professor Melki about the vaccine hesitancy, the impact of COVID pandemic on those issues. And we are also very lucky that since last year, some vaccine has been included in our national program, such as pneumonia, HPV, and starting for this year, so rotavirus vaccine has been included in our national program. So it means that every children have this opportunity to receive this vaccine free of charge. But this rotavirus vaccine produced by India, and next week we hope that our Indonesian vaccine will be implemented in our national program. We hope that this vaccine we call RV3 RBP vaccine has been developed by Prof. Julie. This is a long collaboration, of course, since 50 years. Oh, almost, long collaboration, between UGM, led by Prof. Yati, we are very proud of you, and also by Prof. Julie from Muda Student Research Institute. So this morning we also will learn how the development of this vaccine and also how the implementation, because we know that the development is very, very difficult, but the implementation is also not easy. It's also complicated. So this morning we are very lucky because we have two special guests from the Australia, and from the first time, Prof. Melki, maybe we can look for the CV. Please show the CV. You, Prof. Melki? Okay. Plus,
Well, it's a real pleasure to be here today. I think it's 10 years actually since I was in Jogja, and I played a very small part of the RV3BB story in the early development of the second generation vaccine, so I'll love hearing the story again after me. But I'm going to talk to you a little bit. I'm hoping that this is the right one. I thought it had a different title, but
you can stand or sit, up to you.
Oh, I can sit. I was just wondering how you do it. Oh, this is very nice. Yes, I am very tall. Oh, this is very nice. Okay, and then I can just look at the screen back there. All right, so obviously, with COVID, it's been an incredibly difficult 3 or 4 years now. And what I'm really going to talk about today is the impact of the pandemic on routine vaccination. So it's a much bigger story than just vaccine hesitancy. And of course, we know that vaccines can only work if people actually, if they get to people who need them and they're actually used and accepted. So I'm going to look a little bit at that. So this is the, I'll control the slides, is that right? Perfect, all right. So what I'm going to do is, I actually think this is the wrong talk. Somehow. Yeah, this is somehow, Julie, this is the wrong talk. I'm wondering whether you might need to go first and I have to upload the... this is actually the workshop slides, not my talk for today. I'm not... I do. I can email it. Do you want to perhaps, shall we skip to your talk and then I'll go after you? It doesn't matter, does it?
Yeah. Because when I look for this PowerPoint, so
You were confused as
Yeah,
well.
yeah.
Yeah. I don't know how that happened. Okay, that's all right. All good.
Okay, so yeah. Sorry, because there is a wrong PowerPoint presentation, so we will move on the second, second talk, Professor Julie. I think it's also, so the concerns is also nice. So, Professor Julie, you will, talk about the development of the RV3 BP vaccine and also the implementation. Time is for yours.
Thank you very much. It's a real pleasure to be here. And I will sit down. Thank you. It's a real pleasure after such a long time with COVID not being able to come and visit, and it's a delight that my mentor, my other grandma, my ma, Prof Yati is here today, so that's a real pleasure. I'd like to talk to you about a journey, and it's a journey that extends back for almost 50 years, and it's a journey we've taken together. So looking back into the 1970s, before many of you were doing medicine, gastroenteritis was a major cause of hospitalisation and death in young children worldwide. There were gastroenteritis wards in many children's hospitals, including our Children's Hospital in Melbourne. But the cause of the diarrhoea was not known in over 80% of the children admitted to the hospital, which made it very difficult to target therapy. Oral rehydration solutions were not widely used, and Prof Yati was a big proponent of oral rehydration and worked very hard to get recognition of the value of this therapy. There were no vaccines at that time available to prevent gastroenteritis. And this was the setting of which promoted the discovery of rotavirus back in 1973. At that time, extensive microbiological endeavour was try to culture what the causative organism was, and it was not found. And it was there that Ruth Bishop, a microbiologist in the Department of Gastroenterology, sought to work on a collaboration to try and identify the cause of this devastating diarrhoea occurring in children worldwide. She postulated it might be a virus, and what she worked with was a really good model for ongoing research, a collaboration between clinicians and scientists and public health physicians to try and solve a big problem. And in that collaboration, she worked with the then head of Department of Gastroenterology, Rudge Townley, who used a clinical innovation to take a small bowel biopsy of using a modified cardiac catheter. So modifying that, he took one of the gastro fellows at the time, Jeff Davidson, took a series of small bowel biopsies of children presenting with acute dehydrating gastroenteritis. And up on the top screen there shows the first view from the first child they looked at under a new technology called electron microscopy, which was new at the time at the University of Melbourne. And what they saw was those little round dots invading the small bowel of a child with gastroenteritis. And these small particles were viruses. It was later called rotavirus. And now that that pathogen was identified, it could be looked at worldwide under electron microscopy. And there you are, Yati. And Yati pioneered really the understanding of the role of rotavirus in low and middle income countries as a cause of the devastating diarrhoea seen in many countries around the world. And this is a very pivotal paper which identified that in children presenting to hospital with severe diarrhoea in Yogyakarta, they in fact had rotavirus, and that was the cause. A really pivotal study. Subsequently, when it looked around the world, rotavirus, that should be rotavirus, was associated with more than 600 deaths per year. And each of those red dots represents 1,000 child deaths per year in under 5. We now know a lot more about rotavirus, how it invades the small bowel, what devastation it does to the small bowel in terms of flattening the mucosa, and that's the reason why there is severe diarrhoea. We know the genetic structure, and we know the impact that rotavirus has on the various hormones in the small bowel, resulting in vomiting and the rapid dehydrating diarrhoea. But the understanding of that particular virus and what it structured allowed the potential to develop a vaccine. And now we sit 50 years after that discovery with 125 countries having introduced a rotavirus vaccine into their national or subnational programs. There are currently 4 WHO pre-qualified vaccines delivered orally in either a 2 or 3 dose schedule from 6 to 8 weeks of age. And in every country where there has been a study looking at the risk-benefit ratio, it has been unanimously positive that these vaccines save lives, reduce hospitalisations and are cost-effective. So when you look at this map, there's certainly a number of high-income countries that have been introduced vaccines. There are a number of countries that are Gavi eligible that have been able to introduce vaccines because of support from the Gavi Alliance. However, in our region, there are quite a lot of countries that have not introduced vaccines. And it was great, the landmark introduction in Indonesia of a rotavirus vaccine just very recently. So you might say, well, is rotavirus disease now solved? Well, in fact, rotavirus, despite vaccines, still kill about 200,000 or more children under 5 each year and hospitalises many thousands more. There are big gaps to access to rotavirus vaccines. Just under a half of all children around the world still don't have access to a rotavirus vaccine. Many who have access have incomplete delivery of a full course of a 2 or 3 dose course. And vaccines need to be given early so that it prevents the first severe episode of gastroenteritis to be fully effective. And that doesn't occur in many countries, or all countries, I should say. And again, we look at our region, and a number of countries in our region still are either planning to introduce or don't have plans for introducing a rotavirus vaccines. And there are many reasons that have been that are barriers. Obviously cost, there are gaps in global supply of rotavirus vaccines, there's competition within a busy infant schedule, competition within limited health budgets. There are some preferences in some countries for locally produced vaccines, so waiting for that vaccine to become available. Rotavirus may not be seen as a major need by some populations, as many of us didn't know that such an organism exists. There are continuing concerns about safety, and I can address that later, and there might be other cultural and societal concerns. So there's still a lot of work to do to make sure that children receive a rotavirus vaccine, which is potentially life-threatening, and despite there being a WHO recommendation that all children receive a vaccine. Now, one of the difficulties also with rotavirus vaccines is there's quite a disparity of vaccine efficacy in clinical trials between clinical trial efficacy with vaccines in high-income, low child mortality countries and compared with countries that have high child mortality. And in fact, with vaccine rollout, vaccine effectiveness is quite different, or I would say a little disappointing in high child mortality regions for both the two major vaccines that the data is available. So whilst it's great that vaccines are out there in areas where there is a lot of rotavirus burden, they're not doing 100% of the job that they need to do. And that's really driven the research that we do. There are a number of potential hurdles for a live oral rotavirus vaccine that might be related to the fact that the vaccine has to go through the stomach, pass through gastric acid. It is often mixed with breast milk, which can have antibodies. There are maternal antibodies in the first 6 months of life, which may act that in some countries with high child mortality, there's malnutrition, quite a busy gut microbiome because of the environment in which these children live. Then there are other co-infections like HIV, malaria and so forth, which might interfere with the ability of a rotavirus vaccine to be effective. These are all postulates, and I'm going to address some of those in a moment. We asked the question, is it possible to protect babies, newborn babies, from birth from severe gastroenteritis? And should we target birth as an alternative to a 6 to 8 week first dose of a rotavirus vaccine? And there are potential advantages of a birth dose schedule. It's a great time for immunisation when mums and babies are in touch with a healthcare provider, particularly in the remote regions, and it's a successful immunisation time point for BCG, oral polio, hepatitis B, are all given at birth very successfully. It may improve coverage, the opportunity to get at least one dose in. It may address a gap in protection in the very young babies. It has the potential to improve the benefit-risk ratio, because one of the safety concerns with rotavirus vaccines is a very low prevalence of interception, which is very uncommon in the first weeks of life. And then there is some data from our trials in Indonesia which shows the protection might be a little bit longer. The duration of protection might be longer if you give a birth dose of a rotavirus vaccine. And so also we postulated that maybe giving a birth dose might overcome some of those concerns about what happens to an oral rotavirus vaccine when it passes through the stomach of a baby. The gastric pH is generally neutral or alkaline in newborn babies. There is an immature gut microbiome, and breast milk is often not well established at birth. And so you have an opportunity to provide that vaccine in very early. And we look back to the past. This is a pivotal paper back in the 1980s, done also by Ruth Bishop and Graham Barnes in Melbourne, where they were asked to investigate an episode of gastroenteritis, an outbreak in newborn nurseries in Melbourne. And so they thought, this will be rotavirus. So they went into the nurseries and they collected stool from babies in these nurseries. And what they found was not rotavirus. They found another cause of the gastroenteritis. But they found lots of rotavirus, but it wasn't in babies that had diarrhoea. It was in healthy babies. And a lot of healthy babies in the nursery were excreting lots of rotavirus, but they were healthy. So the team followed those babies for the first 3 years of life, as well as the cohort of babies that didn't have rotavirus in their stool. And what they found in the first 3 years of life is those babies that did have the rotavirus excreting a lot in their stool were protected 100% from severe rotavirus gastroenteritis, compared to that cohort that didn't have rotavirus in their stool in the newborn nursery. So it was almost as if these babies actually had a natural immunisation in their newborn nursery. They were well and healthy, had asymptomatic carriage, and were protected in the first 3 years of life from this natural infection. So we have used this kind of novel rotavirus strain, which seems to be particularly well adapted to the newborn gut and appears to be quite distinct from disease-causing rotavirus strains in terms of not only the structure but also the genetic makeup and the way it functions in terms of integrin recognition. So there's something quite unique about these newborn strains that don't cause disease but replicate very nicely. And it's the basis of this novel, unusual rotavirus strain that is the basis of the RV3BB rotavirus vaccine that I'll talk about a little bit more. This is based on the human neonatal strain, a G3P6 strain associated with asymptomatic infection. We've used that strain to grow up to high titer and develop into a vaccine to be given with the first dose of birth with 2 subsequent doses because it's well adapted to the newborn gut. We know it's health, it doesn't cause disease in the newborn, and so it seems an appropriate vaccine candidate to be used in a birth dose schedule. And we've been working with the team here at UGM and Biopharma to develop this vaccine so it's affordable and able to be implemented here in Indonesia, an Indonesian vaccine to meet for the Indonesian population. So we've been partnering with Biopharma for many years now. And you know Biopharma very well from its ability to be able to produce EPI vaccines for the Indonesian vaccine schedule and also to be able to produce for the WHO pre-qualified vaccines, a number of them for the global UNICEF and Gavi market. We've conducted a number of clinical trials of RV3BB vaccine and Margie was involved in phase 1 and phase 2A and the beginning of phase 2B. In terms of the first phase 1 was done in Melbourne, phase 2A was, first time it was given to newborns was in New Zealand. We did the 2B efficacy study here in Yogyakarta with Yati and Itob and the team here at Pro. And we've also done a dose ranging study in Malawi in Africa to demonstrate whether this vaccine will work well in an African high child mortality area. And Biopharma have also conducted phase 1 and completed phase 3 trials of safety and immunogenicity of the Indonesian Biopharma manufactured RV3BB. And this is the study done here. It was the pivotal proof of concept study looking at a double-blind randomised placebo-controlled study done here in Jogja and Sleman, looking at 3 doses, either in a neonatal schedule with the first dose at birth, followed by 2 other doses, or the first dose in the normal infant schedule at 8 weeks, like the other vaccines. And what we found was that actually the vaccine efficacy was really excellent in the first 12 months of age. And even to 18 months of age was certainly excellent as well and really compared very favourably, I might say, to other WHO pre-qualified vaccines. When we've compared the serum IgA responses at 18 weeks of age in babies who received RV3BB, and we've compared that to the clinical trial data from other vaccines, also RV3 also performs very well. So the efficacy wasn't out of keeping with what we had observed with the serum IgA responses. And we look at vaccine take, which includes the parameter not only of serum IgA, but the ability of the vaccine virus to replicate in the stool. It also is very robust across the studies in New Zealand, Malawi, and Indonesia, giving us confidence that this vaccine does have the ability to take in these babies and produce an immune response, and subsequently, based on the data from Yogyakarta and the 2B trial, produce protection from severe disease. So I would postulate it is possible to protect babies from severe rotavirus gastroenteritis at birth in high child mortality settings, certainly as we've found in Indonesia and we suspect in Malawi also. So go back to some of the more scientific questions about what are the factors that might influence vaccine effectiveness and the duration of protection, because obviously we want to make sure that the vaccine is fit for purpose, it's going to have a prolonged duration of protective. And I've broken these down into 3 major factors that affect vaccine efficacy. One is around the vaccine characteristics, the intrinsic characteristics of the vaccine and its administration schedule. The second part is about the host. There are unique elements of the particular host you're developing, providing the vaccine to. Is there something different about the genetic makeup of populations in different regions of the world that could explain the difference in vaccine efficacy? And the other thing is, a gastroenterologist, I'd like to think about the gut environment in which you're placing that vaccine. And is there something about the gut that promotes vaccine effectiveness or not, or creating a barrier to these vaccine uptake? So a couple of things in that original process, what are the barriers to oral rotavirus vaccine uptake? One is, importantly, with Rotarix in particular, there was observed very early on that oral rotavirus Rotarix did not appear to, when co-administered with OPV, didn't it appear to impair OPV immunogenicity, but OPV immunogenicity seemed to decrease the oral rotavirus vaccine immunogenicity, in particular after the first dose. And there was low vaccine virus shedding in the stool also. When we've co-administered in Jogjakarta trial, we had one group that had oral polio vaccine and one that had IPV. We found that there was no difference in the serum immunogenicity of either vaccine. So RV3 did not appear to reduce oral polio immunogenicity, nor did the oral polio impact on the RV3BB immunogenicity. So we believed it was safe, and there were no concerns about reduction of vaccine efficacy when co-administered with oral polio vaccine. One other postulate is that there's something about the genetic makeup of people that might influence the ability to take up an oral rotavirus vaccine. And histoblood group antigens, which are your blood groups, they actually offer are important in the gut. They line the gut. And enteric pathogens often use histoblood group antigens as a first step of cell attachment and entry into the cell in promotion of infection. And there are susceptibility factors for rotavirus, wild-type rotavirus infection in a P-dependent way, depending on the type of rotavirus. And Lewis and secretor status does impact on wild-type infection, and with non-secretors being more resistant to wild-type P8 infection. So considering the major vaccines, particularly Rotarix and Rotatec, have P8, this was one question whether that nature of those Hello?
Yeah.
That's good. So maybe it's the fact that those vaccines had P8 and therefore people who are non-secretors weren't taking up the vaccine in the gut, just like they weren't for the wild-type infection. And there's always been a concern or an intrigue of why there is a difference in genotype distribution around the world, with some genotypes more present in some populations and other genotypes more present in other populations. And in particular, in Africa, there's a higher proportion of disease-causing P6 strains than in the US or Australia. So and there's a higher population of weak secretors or non-secretors and Lewis negative in African populations and also in Asian populations. So we had a look at this in our trials in, this is data from Indonesia, which was just published. Going back, RV3BB is based on a P6 strain, so we thought it might suit well for Africa in particular, which have a lot of P6 strains that are not being, the efficacy of the P8 rotavirus vaccines did not appear to be as good. And what we found that RV3BB produced a positive vaccine take, serum IgA seroresponse, neutralising antibody response, stool shedding, irrespective of the secretor and Lewis antigen status in Indonesia and in New Zealand. So it appears that because the P6 is ambivalent to blood group status, this might be a good thing in that the vaccine take might be stronger or better or more broader, irrespective of your histoblood group status, which you can't change, you're born with. So maybe this might help with vaccine efficacy. So then just going on to the gut environment and looking at the various factors around enteric infection. Environmental enteropathy in some countries is a big problem in infancy and young children. The impact of gut development and mucosal immune development, which is very complex. I mean, the gut has more immune cells, more nerve cells, more bacteria than any other part of the body. It's a very complex environment, and that changes a lot in the first week and month after birth, because you've got a fairly sterile environment in the gut from birth, and there is you're born IgA deficient until you are able to make your own IgA, not like IgG, which you get transferred across in the placenta. So we thought we'd look at this a little bit. There have been a number of studies with other vaccines and really haven't been particularly informative. There have been occasional downs and ups of various diversity of the gut microbiome, whether that influences vaccine take in different countries, but not very convincing. When we looked at, this is one snapshot of data, when we looked at RV3BB development of the gut, in newborn gut at 6 weeks, 12 weeks, either 14 or 18 weeks of age, in Indonesia and in Malawi, we showed actually a relationship between the ability of the vaccine to shed and the diversity of the gut microbiome. So it's hard to know which happened first, whether the vaccine promoted a greater alpha diversity. That's good for babies' health. It means that they have a diversity. You're not getting a predominant growth of kind of bad bacteria. You've got a diverse bacteria. And this effect was greatest in the new neonatal schedule compared to the infant schedule. So getting the vaccine in before the gut, its microbiome has developed, seems to be a good thing. And I don't know whether, I don't think I have the next slide because I can go into this in more detail, but the bacterial taxa that are promoted appear to be more beneficial taxa than gram-negatives and staph streps that occur in the absence of the RV3BB in the placebo group in Indonesia. So it might be that there is some, certainly not a bad thing having a live oral vaccine at birth, but it actually might promote a better microbiome, which might have subsequent beneficial effects. A postulate still, but it's interesting to know that there is a difference between those that receive a neonatal vaccine at birth in Indonesian babies and in babies in Malawi. We're following this up actually looking at the virome, because bacteria, the microbiological milieu of the gut is evolving, and there are a lot of viruses in the gut, and just like the bacteria, it's just we haven't really thought about viruses as part of that complex microbiome, and we're certainly seeing some changes as also between those that have received a live viral vaccine at birth versus those in the infant schedule that do not. Watch this space. We found that maternal antibodies had no effect on RV3BB vaccine take in infants in Malawi, and this duplicates Margie's work in New Zealand, which means that we can feel confident that we can give babies at birth, when there's lots of maternal antibodies around RV3BB, and it not be greatly impact on vaccine take. So the question being is that could RV3BB, this kind of unique, unusual virus, given in a birth dose schedule, improve the opportunity for rotavirus vaccines to make an impact on child health? And I think I've divided into two things. There's a potential impact of the birth dose schedule to provide early protection, improve coverage, limit the challenge to vaccine uptake, might have some benefits of safety profile, and maybe increase the duration of protection. And then there's the issue about something about this neonatal G3P6 rotavirus strain as a vaccine, RV3BB, are related to the intrinsic characteristics of the vaccine that might not only target circulating P6 strains that are not well targeted in countries where this is an important cause of diarrhoea, but might improve vaccine take irrespective of blood group status, can be co-administered with OPV without a reduction of immunogenicity of the vaccine, and may improve the vaccine take. So there might be a couple of reasons why this might be a reasonable strategy. So importantly, developing a vaccine needs to also consider important information for decision making, and that's where the team here have been incredibly influential, providing the information needed by your ATAGI to make a decision whether a rotavirus vaccine, in particular RV3BB, might be suitable for Indonesia. And this is work by Professor Jaria and the team here in MCRI, looking at the cost effectiveness of introduction of a birth dose versus an infant dose of RV3 versus other vaccines available, and showing that actually RV3BB looks as though it's going to be highly cost effective in Indonesia in reducing not only child deaths, hospitalisation, outpatient visits, and also loss of income to families who are got to tend to a child who has an episode of gastroenteritis. So it meets it easily in this context. We also did a dynamic model looking at the estimated impact of RV3BB vaccine, and Vigor Octario was part of that group from the School of Population Health and at the University of Melbourne and MCRI. And they estimated there would be a 95 to 96% reduction in infection and disease in less than 12-month ages if the vaccine coverage of RV3BB was 85%. But even if you reduce that coverage to 55%, there'd still be an 84% reduction in infection and disease with vaccination. And with high levels of vaccine coverage, there was actually identified on the model a significant impact of indirect protection, with a 78% reduction in infection in adults greater than 17 years, suggesting that by reducing the burden of rota in the community, this would have potential impact. And knowing that actually the burden, certainly in Australia, the burden is a bit like a U-shaped curve. We underappreciate the burden in elderly of diarrhoea and rotavirus. So these are important bits of information to provide to the government and ATAGI about decision making of the impact. And this has been a wonderful journey over this time. This was taken in Bali just in March when we were celebrating where we got to and waiting for the opportunity to repeat this, Prof. Yati, when we've got final licensure and rollout of the RV3BB vaccine. But it's been an effort over decades, and 4 to 5 decades of work, from the discovery, identification here in Jogja, and communicating that globally and development of vaccine. And it's been a wonderful journey. I've been really delighted to be part of that, and the wonderful friendships over this period of time. I hope I've convinced you that rotavirus vaccines have a potential to make an impact on child health if they're delivered and globally delivered. But there's still work to be done. Rotavirus, unfortunately, still kills many, many children worldwide. There's still gaps in access for vaccines. There's gaps in coverage. There's gaps in supply. There is still a suboptimal rotavirus vaccine effectiveness in lower middle income countries. And we'd like to see RV3BB out there to address some of those things, to contribute to supply, to improve the coverage by providing a birth dose, and potentially improve the potential that a rotavirus vaccine has to improve child health. And there's been many people on this journey. Prof. Yati is certainly there, and Margie, and many, many people you would perhaps recognise over this this journey, to the babies that were in the trial, to the midwives that were involved in the 2B study, and some of our funders and people along the way. So I'd like to thank you, Prof. Yati, on behalf of our team and our work, and it's been an absolute joy. You've led a fabulous team, and I hope we're going to see this go full circle, and from discovery to implementation here, and get the vaccine out. So thank you very much for your opportunity to talk today.
Okay, thank you very much. It's very, very interesting yeah, lecture, and I learned many from your presentation. Yeah, because so we are very happy that the zero dose, the neonatal dose is very important because you mentioned about the benefit, the difference between neonatal dose with another vaccine type vaccine, like you mentioned another rotavirus vaccine. So we will do the discussion after. Marky, do you have your presentation already? Okay, yeah. So we will continue from the next lecture. Prof. Marky, time is for yours.
Thank you. I love listening to the RV3 story. That was just so fabulous, Julie. Thank you. All right, so now it actually makes a lot of sense for me to speak second, actually, because what I'm really going to touch on are those factors that Julie talked about in terms of access, supply, coverage. That's really what I'm touching on. And I hope by the end of it, I'll convince you that it's certainly not all vaccine hesitancy. All right. So hopefully we are good to go. All right. So really, one of the most common questions that I get asked, so I lead a team of people at MCRI, it's the vaccine uptake group, and really these are the questions we look at. Coverage, what impacts coverage, and how can we really address the situation in Australia but globally, and particularly in the Western Pacific region. And one of the most common questions we get asked is, well, has the pandemic impacted hesitancy? And what has been the impact on coverage and vaccine confidence? So I'm going to talk a little bit about that in Australia and from a global perspective, and then look at what has influenced those drops in coverage. And then I'm going to introduce you to a framework to try and understand the factors that actually influence uptake of vaccines and talk about the WHO framework. And then I'm going to talk to you about some of the strategies that we have been involved with in Australia and in the region to try and actually improve coverage and what we need to do now. So first of all, from an Australian perspective, what has happened over the last few years with COVID? Well, there's been about a 1% drop in coverage. In Australia, we measure our coverage rates at 3 time points, at 12 months, 18 months and 5 years, although it's really measured at 4 years. And there's been a drop at all time points in coverage in Australia. And you might say, well, 1% isn't a very big drop, but that actually represents a significant sort of number of children, at least 20,000 children in Australia. And in terms of human papillomavirus or the HPV vaccine coverage, you can see there's also been a substantial drop. You've got the girls in blue and the boys in red. And then really want to draw your attention to our Indigenous or First Nations young people. And you can see particularly a drop there for First Nations boys, right down to sort of 60% or so. And I'm sure you're all aware at the moment of the global focus and push on increasing HPV vaccine coverage, particularly for girls, and addressing the burden of cervical cancer. We also have a very strong flu vaccination program in Australia. It's funded for children 6 months to 5 years, so it's free for those kids. But you can see there that we've had a significant reduction in flu vaccine coverage through the pandemic. You've got in red there the 2023 data, and 2020 is in grey. So it's quite a substantial drop there as well. And unfortunately, also in the 5 to 15-year-old age group, and this year in Australia, that was the age group that actually had the greatest burden of disease, with the most number of deaths, and particularly due to flu B. So there's a lot of discussion in Australia at the moment for funding the vaccine for that age group as well, because we know if the vaccine is free, that parents are more likely to accept it. But certainly impacting coverage across all those vaccines. So the Commonwealth Government actually commissioned a national survey in April last year to look at community attitudes to routine vaccination. And you can see there in that figure on the right, both in the for parents of younger children under 5 in the grey, and then of parents of children 6 to 12 years in the sort of blue colour. And what I want to really show you is that there was a decline in strong support for routine childhood vaccination for parents in both age groups. So you can see there for the younger kids, a decline sort of from 70% to 50%, and similarly in the 5 to 12-year-old group. And that's really concerning. There's no real reason why there should have been a decline in support for routine vaccination through the pandemic. The vaccines were the same, and it really sort of highlights this complex interplay of factors that occurs. And also with the COVID vaccines, and particularly the mRNA vaccine platform, there were a lot of vaccine safety issues around myocarditis, but even with the other vaccines, the viral vector vaccines, AstraZeneca, with the clotting severe adverse event, you know, the strong scrutiny on vaccine safety has really impacted confidence in routine vaccination, which is quite concerning. And you can see there, obviously, the support, for the percentage of parents that just support vaccines has increased, but what's more worrying is those that are refusing vaccines has also increased as well. This is also really interesting, that there was a decline in the perception of individual vaccines. And again, there's no specific reason for this. The greatest drops in support were for meningococcal vaccine and pneumococcal vaccine, really worrying sort of trend. There was, and you can see here, I mean, it's very small, sorry, but you can see in terms of some of the attitudes, there was a reduction in the belief that vaccines, so I've seen or heard about bad reactions to childhood vaccines. I believe some vaccines are safer than others. A lot of these perceptions changed. There was also a bit of an increase in some of those parents that really did believe vaccination was safe and important, but strong impacts on attitudes to routine childhood vaccination. So this is really a summary of what we think has impacted routine vaccination in Australia, and I just want to really draw your attention to the first heading around practical issues. So still access barriers or practical issues almost certainly have the biggest impact on coverage in most settings. And in COVID, we saw that parents were really afraid to access healthcare services. It was harder to get an appointment. Parents still don't take their children to be vaccinated if they have an intercurrent illness, even if they don't have a fever. But of course, there was an impact in terms of confidence in the vaccines, a lot of vaccine fatigue. Parents just didn't want to hear about vaccines anymore. There was a reduction in the belief of the community benefit of vaccines, and still that persistent belief that too many vaccines are given at once. There was also a really important sort of new element or factor that we became aware of through the COVID vaccine programs, and that was reduced trust in government and healthcare providers. And this was also very strongly influenced by the very wide use of vaccine mandates for the COVID program. And there's a lot of really interesting research going on in Australia at the moment looking at that as well. So that's really the Australian perspective. What about globally? I'm not sure if you've seen the UNICEF, the 2023 UNICEF State of the World's Children report, but I strongly recommend you have a look at it if you haven't. It's quite concerning. So through 2019 to 2021, 67 million children missed out either entirely or partially for their routine vaccines, and 48 million children are what we call the zero-dose children. They didn't get any vaccines at all. And from an operational perspective, that's really defined by Gavi and WHO as those children who didn't get the first dose of the DTP vaccine. But that's pretty concerning. So there was actually a 40% increase through the pandemic of zero-dose children. There has been some recovery. Some of the data from last year in 2022 is reassuring. We are seeing some of the countries that saw a significant backsliding in vaccine vaccination recovering, but a lot of them are stagnating or actually getting worse. So the situation globally is very concerning, and there have been calls this year from WHO, Gavi, UNICEF and many global partners to really look at how we can reduce the backsliding in routine vaccination and particularly address the issue of zero-dose children. So in terms of our region, these are the countries I really just wanted to draw your attention to in terms of the highest number of children who have not received any vaccines. So we're working and starting projects that are funded by the Australian government looking at zero-dose children in both the Philippines and Indonesia. And as you can see, the Philippines are rated 4th and Indonesia 11th. Indonesia has shown a lot of recovery, particularly in the last year, but there's still a lot of work to do in terms of reaching every child and really strengthening routine vaccination and reducing zero-dose children. And we've also got a program of work in Vietnam. So we've tried to really support and answer the call from the Ministries of Health in those 3 countries around addressing these challenges. This is some really nice data from Heidi Larson from the Vaccine Confidence Project, looking at the impact on vaccine confidence globally. So you can see here those countries down the bottom. If I go back, there's only 3 countries where vaccine confidence has not been impacted at the top there, China, India and Mexico, but all of the other countries have had a significant reduction in vaccine confidence in routine vaccines, particularly amongst younger people or younger age groups. And that's concerning because those are the people who are parents. And the country there, those countries down the bottom have had nearly a 50% reduction in vaccine confidence. So that's Papua New Guinea, a lot of African countries, South Africa, really concerning impacts on their vaccine programs as well. So what has happened? Why has coverage dropped? Well, there's definitely been an impact on confidence, as I've just shown you, and an increase in hesitancy, but it's a lot more complicated than that. You know, the pandemic really amplified some of the challenges in primary healthcare and weakened healthcare systems. There's been huge demand. There've been exacerbated existing shortages of healthcare workers. And really, you know, a really interesting study that was done here by our team and with UNICEF in sort of April, May last year in Indonesia showed that the healthcare workers have reported significant burnout and an impact on their mental health. They really struggled here in Indonesia, and that's actually been echoed globally as well, the heavy strain on those frontline healthcare workers, and we know that that's mostly women. So there's a lot of work that we need to do looking at the healthcare workforce and taking into account the impact of gender. I think I've talked a little bit about the stay-at-home recommendations, you know, the lockdowns and how people didn't access services. And in terms of hesitancy itself, I'm sure you're all aware of the sort of exponential growth in misinformation that has occurred online and on social media, and I've talked a little bit about the declining trust in authority and governments, and of course there's been a lot of political polarisation as well, and that was very much evident in the US in particular. So this is the WHO framework. It's called the BESD or the BESD framework on how we try and understand the drivers of vaccine uptake. And this is a really nice framework to get your head around and think about for all of you who are thinking about designing projects and potentially doing research in this space, because these domains are very much, you know, they don't capture all the barriers to vaccination, but these are the domains that are amenable to strategies or interventions that might be able to improve coverage. So I'll just quickly take you through it. So what you've got on the left there is what people think and feel about vaccines. So this is perception of disease risk, understanding of vaccine effectiveness, vaccine safety, concerns that parents have, confidence in vaccines. And then importantly, the social processes domain is really looking at making vaccination the norm. So the support of religious leaders, community leaders. Do healthcare workers actually recommend vaccines? What is the impact on gender in terms of women making the decisions in their household for vaccinating their children? What is the impact of fathers and the vaccination for girls? So both what people think and feel about vaccines and those social processes impacts intention to vaccinate or motivation to be vaccinated. And that's really that hesitancy bucket. But then, even if you intend to be vaccinated, there's lots of reasons why you don't actually get your children vaccinated. And those are those practical issues. And they really moderate that kind of pathway to vaccine uptake. And that's, as Julie highlighted with the RV3 vaccine, is it available? Is it affordable? What is the supply? Can people access it in the clinic? What is the service quality of providers? And those practical issues, as I said, really in many situations are the major barriers to vaccine uptake, not intention to vaccinate or vaccine hesitancy. So there's lots of reasons why people are motivated to receive vaccines. They need to really appreciate the disease risk. They need to be confident that the vaccines are safe and that they work well. They need to trust the vaccine development process. That was a really big issue in COVID, as I said, particularly with the mRNA vaccine platform. They need to trust in their government and the health system, and healthcare providers actually need to recommend the vaccines. And then, of course, the vaccines need to be convenient. But most of these factors are influenced by effective communication, which is really what I'm going to talk about next, is what are some of the interventions and strategies that we can use to really impact some of these factors in terms of motivating people or increasing demand for vaccination. So this is a really nice table that summarises those factors on the left, what people think and feel about vaccines, the social processes and those practical issues, and what are the interventions that have been shown to be effective to actually tackle those domains. And pretty much I've highlighted there in the red those interventions that are reliant on improving effective vaccine education and effective vaccine communication. So, really good in campaigns to inform or educate the public, dialogue-based interventions, and from my point of view, what I'm really particularly passionate about is really strong grassroots community engagement interventions, vaccine champions and advocates for vaccines in the community that really promote vaccination as the norm and encourage parents to accept vaccines. So here's a couple of examples of these sort of communication-based interventions or strategies. In Australia, this is more around COVID. I was very involved. I was seconded and working with the government for a large part of the COVID vaccine rollout. I worked closely with the Australian Academy of Science to develop different resources, videos, campaign materials around the COVID vaccines. At the moment, the Australian government has just developed a fantastic routine immunisation healthcare provider toolkit, which has been released with terrific resources for First Nations parents, but also just for providers around what do they need to do, what are the key messages to answer common questions, how to support conversations with parents, and really how to also follow up and identify those kids who've missed their vaccines. And the one on the left there is just a fantastic video that was released during COVID in New Zealand around the broader benefits of COVID vaccination, because really thumping people with how severe COVID is, really after a while wasn't working. We had to encourage people that the way to vaccinate, the reason to vaccinate was actually those broader benefits, getting back to their life, kids being able to go to school freely, families being able to visit their elderly grandparents in aged care services and homes, really getting back to the life that they had before COVID. There were lots of other ways that you can reach people with campaigns or strategies. So down the bottom there, one of the professors who was very prominent in the COVID vaccine campaigns and the rollout in Australia was Professor Sharon Lewin and Professor Terry Nolan. We ran a number of what are called public town halls with the Doherty Institute, where we had sort of a couple of hundred people in the room and thousands of people online, and we just answered questions about the vaccines for 2 or 3 hours. And these were run 2 or 3 times, were moderated by somebody from the ABC, a particularly well-known ABC announcer called Michael Rowland, who resonated with the public. And that wasn't hijacked by, crazy anti-vaxxers, thank God. And that's a really effective way to answer questions that people have. Not everybody wants to read dense information on a website. And I think if we're going to actually answer people's questions, you've got to be really willing to step up and just take questions in a public forum. The one up the top there was just some short videos that I recorded for the University of Melbourne. I think I did about 50 different videos, 90 seconds, just answering specific questions about the vaccines. Again, people might want to watch or listen to information, not read information. That was supposed to be translated into different languages and have different culturally diverse faces recording these vaccines, but we struggled to be able to do that, so they were sort of stuck with me doing it. The one in the middle was a podcast that we ran for our Melbourne Children's Campus, where again we ran Instagram live sessions, public town halls with in the hospital, and these podcasts to answer questions for parents. So lots of really creative ways that you can do to promote confidence in vaccines and really reach parents and answer their questions. This was a intervention that's been developed over the last 8 years by myself and another professor in Australia called Professor Julie Leask. This has now been adopted nationally by the Commonwealth Government. It sits on their website and on the National Centre for Immunisation Research and Surveillance website. And essentially it has 2 domains, and this might be something that you might think about doing in Indonesia. It has a domain for parents and a domain for healthcare providers, where we've got all sorts of tools and resources about how to have effective conversations, and resources that providers can use for discussions around maternal vaccination, childhood vaccines, adolescent vaccines, adult vaccines, as well as specific vaccines like flu and COVID. So this has been a real labour of love and is now used nationally in Australia. So I might skip over this, but this is often what we're asked. So when you have a conversation with a parent, how do you have an effective conversation? How do you really address their questions and concerns? And essentially it's about really understanding where they sit on the vaccine hesitancy spectrum and really being willing to listen and to address their concerns, acknowledge their concerns, share trustworthy information, try and address misinformation, use a lot of personal stories and narratives. I always come back to actually discussing the severity of the disease and then recommend vaccination, explain where they can go. I work in our immunisation clinic every week at the Royal Children's Hospital in Melbourne, so I talk to parents and pregnant women every week. And this is a real skill to be able to effectively have these conversations and address concerns and not get into a really aggressive debate or conversation, particularly with people who are anti-vaxxers. Through COVID, we needed to really use specific tools around clinical risk communication, weigh up the risks and the benefits. There's been a lot of research done on how to best do that, decision aids, different numerical risk formats. I won't go on about that, but there's been a lot of really exciting research to move that forward. And also how to support parents to particularly communicate about vaccines with children. And this was a lot of work I did with the Victorian Government about developing resources for them. I won't go into how to address misinformation and disinformation in too much detail, but I'm sure you're all aware just how difficult this is. Misinformation spreads further and faster than the truth. It's really sticky. People are more likely to believe it. Often the anti-vaxxers promise that they have the answers. They really appeal to people's emotions. They drive fear about vaccines, and it's really difficult to address misinformation. There's a lot of exciting work being undertaken by WHO and SABIN and UNICEF around teaching people to understand how misinformation is spread. So these particular sort of 5 tactics that are used to spread misinformation. So there's a kind of a new game, a really innovative new game, digital game that's being developed by WHO to teach parents to understand how information is spread, and it's called Cranky Uncle. I won't go into it, but it's a really interesting strategy that's being developed for parents and young people to play, to be able to identify those 5 strategies that spread misinformation. And in terms of addressing misinformation online, we use something called the Truth Sandwich, which is kind of a fun way to really, talk about the truth up front. People remember what they hear first and last. So if you're going to rebut misinformation, you should always do that in the middle of your conversation, talk about, provide evidence, but really always come back to stating the truth first and last, and not dwelling on the misinformation, because that can often be sticky in what people remember. So the last strategy that is really effective is sort of community-based interventions. And this is really having trusted members of the community, healthcare providers, but broad community advocates being able to advocate for vaccines, talk about vaccine safety and effectiveness, and answer questions. And we did this a lot in Australia, particularly in Victoria with the COVID vaccines. We ran a number of webinars and face-to-face sessions with different cultural groups. That picture in the middle is with a group of Somali women, but the one down underneath that is a webinar we did with a couple of hundred members from the Arabic community. And we've really taken this program to the Pacific and have rolled out programs like this in Fiji, Tonga and Vietnam, where we've co-designed these community-based interventions with the government and partners, so WHO, UNICEF, Red Cross, to really understand what vaccines the country wants to target. So for some countries it was the COVID vaccines, the boosters in Fiji, and the COVID vaccines for children. In Vietnam it was very much around routine vaccination, co-designing a program and then running a train the trainer program where you train master trainers who then train healthcare workers who then move into the community and train community vaccine champions. And we have some really exciting effectiveness data on these programs actually improving coverage, improving knowledge about vaccine safety and effectiveness, and really improving confidence. So coming back to what I was talking about at the start, if we're really going to move this needle, we've got to do grassroots interventions to do that. And we had an opportunity in Victoria to celebrate the work of the amazing campaigns that were run in the community in Victoria at a conference in the middle of last year, which was run by our Chief Health Officer, Professor Brett Sutton. You can see there with the mask on, and really an amazing opportunity, a day to thank all of the people who were responsible for the COVID vaccine rollout in Victoria. So, but I've talked a lot about, interpersonal communication, good vaccine communication, but from a public perspective, we really need to do this better as well. So this is really about our public health leaders, our government leaders, being able to communicate transparently, to highlight when they don't know things, rather than just sort of make information up, which is what we saw a lot, or not being transparent about the decisions that they make. So these are some of the core things that we need to see about using clear and actionable messages, promoting vaccination but being honest about the vaccine safety issues, and not pretending that vaccines are 100% safe. Really diversifying communication channels and platforms, addressing misinformation, using different channels for different groups, not actually thinking about where people access their information for different Indigenous and First Nations communities, different cultural groups, and being aware of vaccine equity, using credible spokespeople. So there's a huge amount of work that's been going on now. We're finally in Australia developing our new Centre for Disease Control, which is going to be established in Canberra early next year. And this is what they're looking at. how can we actually do this better? How can we actually communicate with the public? How can we train our government and public health leaders to communicate really important information about vaccine programs, ATAGI advice, better than we did during COVID? So in terms of tackling this backsliding and routine immunisation from a global perspective, I hope I've convinced you that what we need to do is really engage with communities and promote dialogue. We need to support healthcare providers and give them the tools to be able to have effective conversations with parents and adults. We need to understand what the vaccine concerns are and what misinformation is circulating in communities, and we really need to be aware of the impact of gender and empower women and girls. But also, we need to look at ways to strengthen primary healthcare. One of those ways is to support healthcare workers, but we need to integrate immunisation services into broader public healthcare programs better. And this is a key focus at the moment. We can't just focus vertically on immunisation programs. We really need to be looking at other programs that are being conducted in primary care and look at sort of the complex financing and other issues as well. So, in summary, the pandemic has definitely increased hesitancy, but the biggest effect and impact on coverage has been those access factors, which I talked about. So really, if we're going to improve coverage in different contexts and settings, and it's very complex, we have to be able to diagnose and understand the different access and acceptance factors so that we can actually develop effective interventions to target them. And this really needs to be done better, because we waste a lot of money by doing expensive campaigns when that's not the problem. If the issue is access, why are we spending millions of dollars on campaigns, broad-based community campaigns, if that's not the issue? So we need to build confidence and strengthen primary health care. We do need to look at ways to improve vaccine communication so that we can support intention to vaccinate. And I've talked about some of those campaigns and strategies and dialogue-based interventions. We do need to influence social processes and look at the power of really strong and effective community engagement and the use of these vaccine champions. But my final take-home message is really, it's those practical barriers, supply, access, that have the biggest impact on vaccine uptake, and Julie talked about them as well, and we can't forget those. It's the most frustrating thing of all for me is that people think, especially when I talk about research, that it's just about vaccine hesitancy, and it is absolutely not. It's all of that if we're going to move the needle on uptake and improve coverage globally. So I have a lot of people to thank. I work globally with WHO, UNICEF, the Ministries of Health in all of the countries that I'm working in, and of course my team and all my other collaborators. So I'll stop there. Thank you. And Julie, you can come up. Do you want to answer some questions, or I don't know what they want to do?
Okay, so time is for the discussion. Okay. Both speaker is very interesting, and yeah, the topic. Yeah, I think the time is not enough. Yeah, because there are many information that both of you give. So yeah. So the time for the discussion. Who will? Okay. Please. Your name and.
Oh, sorry. Thank you very much for the opportunity. Congratulations for Prof. Julie and Prof. Margie for your presentation. I am pretty excited for your every sentence, every word that you have been delivered to us. It's pretty brainstorming for me. Okay, I am Wahyu Triatmajani. You just can call me Wahyu. I am graduate student of public health as well as research assistant from Pediatric Research Office. For both of you, I have 2 questions. Okay, sorry if I have too many questions because I am I am too enthusiastically joining this guest lecture. Okay, for Prof. Julie, I might ask about the implementation of the vaccine, because you said previously that RV33B can be given or administered at birth dose, if I'm not mistaken, right? Okay. When giving the vaccine at the birth dose, there might be several potential problems, especially for the make suring the availability of the vaccine, because in Indonesia there are so many mothers who deliver their babies at home or being not attended by the health worker, and the other thing is but when giving at the birth dose or neonatal dose, many mothers postpone the postnatal care because usually mothers take their babies to vaccination when visiting the postnatal care. And I am currently conducting this research for my thesis. And how to make sure or how to resolve these kind of problems. And the second question is, what are the other potential problems or barriers in vaccine distribution, especially to rural areas? Because in Indonesia, we are very, we face so many problems with the rural areas because there should be any problems related to the vaccine chain distribution, right, like other type of vaccine. And that's for Prof. Julie. So next for Prof. Margie. I'm sorry, Dr. Maineni, I have too many questions.
So where will we stop there?
Oh, you are going to...
Because I only remember two at a time.
So maybe, yeah, Prof. Julie,
Okay,
you
okay.
can answer first.
So
Yeah.
the issue of birth dose, it depends on the local context of what's practical. It doesn't actually have to be at birth. When we did the 2B study, it was in the first 5 days following birth that we did within the clinical context. The concept is that you can give it as early as you can. And so, and that it's not, hopefully the first dose is not 6 or 8 weeks of age when you give your first dose of DPT. So in some countries like Africa, the best time is the
like
base. When the baby is first born and the mum's going to go home in the first 24 hours after the baby's born to give the vaccinations before they leave. And so what I'd probably ask back to you about, this should be part of the normal, when OPV, you give your OPV, when you're giving your hepatitis B, usually those are done early, I presume. I think in Indonesia they are done pretty early after birth.
Yeah.
So
As
the
soon as
midwife
possible
would-
from the OPV. So
Yeah.
maybe we can do the same time with because you mentioned that there is no effect of OPV in the efficacy of
Yes.
rotavirus.
Yeah,
MPV.
so you can give them at the same time. So whatever it fits into your normal program for your other birth dose. So I think BCGs might be given a little later. Is that right?
BCG.
Yeah.
BCG is also usually given in the same day. BCG and OPV. Yeah, but OPV maybe is more.
Yeah, and presumably in the future, OPV will be replaced by IPV, or just give oral rota instead of OPV. So whatever fits into your normal schedule, it doesn't have to be done at birth, whatever it works for you. And the second question is about distribution. The distribution will be this should not be an additional burden on your distribution. It just should follow the same distribution, given at the same time as your other birth doses or DPT doses, and should be just part of that normal chain of custody that is available. I think the biggest challenge for the RV3BB vaccine is that it does require refrigeration, and so it does require cold chain. Yeah. And it will be similar to the OPV. So currently OPV does require, I think, -20.
No, OPV do until 8. So it's
Okay.
the similar
so
with the
this
other
is
vaccines.
And it will be the same.
Yeah.
It'll be a central -20 at the central depot, which I think OPV is, and then distributed out to the regions at 2 to 8. It'll just follow the same. So, I mean, obviously if you're having challenges with distribution with oral polio vaccine, you will have the same challenges with RV3BB. That won't change dramatically. Does that make sense?
Sudah cukup
Yeah.
menjawab? It's not-
Okay, I get it. Thank you, Prof. Julie. So for Prof. Margie, I also experienced about countering attack the misinformation during COVID-19 pandemic, and it was pretty exhausting actually. But what I want to ask you about, previously you say about you may hear people that being receive our information from our effort to give effective communication. How to make sure this kind of people absorb our information entirely, so our message can be delivered and they can actually do what we want. And then the second question is how to maintain the sustainability of the benefit, the effective communication towards the society, because at the beginning, society seems to be very enthusiastically, and because they got 100%, but at the middle of the process, their motivation might be decreasing. So how to maintain the benefits of our effective communication for our society? Thank you.
Yeah, they're both great questions, and I should have said actually, we are just starting a project with UGM with Dr. Maineni, Risalia, Dr. Vika, Octaria, doing exactly this. So we're going to be working across 10 provinces with the highest numbers of zero-dose children to train healthcare workers, religious leaders and young people to have effective conversations and advocate for vaccines in their communities and to conduct sessions. And part of what we need to do at the start is this really comprehensive understanding of what the issues are, what the barriers are, and then co-design the modules and the training together. So that's the most important thing, I think, is really understanding what the issues are, what are the concerns in the communities. And of course that's going to differ by province. It's going to be really important that we tailor the actual training that we provide specifically to the context. Then the important thing is to train the person who's delivering it, so whether that is a healthcare provider or whether it is somebody else in the community, a religious leader, a young person. We need to give them the vaccine knowledge. We need to give them the education. Often providers don't have the information at hand on the vaccine safety or the vaccine effectiveness that the parent is asking them. So key facts, really understanding how to answer the question, but then also actually giving them the skills, because effective communication is really hard. I've been doing it for 20 years and I'm still learning. So, we run role plays, we actually teach people the skills. I showed you briefly the format of that conversation, but it's a lot more complex to actually teach someone to do it well. So when you said how can you make sure that the person listening actually receives your information, that comes back to effective communication, and it's really hard. So you actually have to do hours of role playing, and we do that in groups of 3 where you have a person who plays the provider, a person who plays the parent, for example, and then an observer, and you go around and you each have a go in the different roles and you practice the strategies and the skills and you get feedback. And the more you can become better at communication, using those communication skills, the more likely the person is to receive the information that you're giving them, right? But there are still going to be some anti-vaxxers who will never accept what you tell them, and that's okay. But actually most people sit in the middle. Most people sit on the fence. So we do have an opportunity to change people's minds, but you've got to give them the facts that they want, and you've got to communicate in such a way that they will listen and that they will hear you. So that actually is a skill, and that's going to be the focus of this training program that we're doing with the UGM team, with UNICEF and with the government. That's what I'm going to be doing in Jakarta on Monday and Tuesday, is getting that program off the ground. So that's the first thing. And the second question was...
how to maintain the sustainability of the information.
How do you sustain it? Well, that's a really good question, and that's what the Ministry of Health are asking us. Okay, so we're going to run this training, we're going to deliver it, then what? How do you keep it going? So the sustainability is absolutely critical, and the only way that can happen is by local ownership. So the Ministry of Health in the region, whether it's at a national level or a sub-regional level, they have to own the program, they need to maintain it, they have to continually update it and run capacity building and training sessions for the healthcare providers, who are usually the first people that we access. So it has to be owned, and that's why the co-development, the co-design is so important, because nobody's going to accept and sustain a program if they didn't develop it. So, you know, that whole co-design process is absolutely critical for ownership, local ownership and sustainability. So, but, you know, this program is going to be developed and rolled out in 10 provinces. And then there's already interest in rolling it out to other, there's 34 provinces in Indonesia, is that right?
No,
38?
yeah, because
So they're
more.
already talking about, well, that's fine, you're doing it in 10 provinces, what about all 38? I'm like, oh my God, I'll be retired by then. But no, that'll be what Dr. Maineni and the team do. So, you know, the sustainability, but providing these skills everywhere we go, this is what they want, capacity building, particularly for healthcare workers, but other advocates as well.
Yeah. So we hope that maybe Yogyakarta is not zero dose. Yeah. So maybe we can, after the implementation of the 10 province, we can also do in our province. Yeah.
Very much so.
Okay. So also
You should be involved in our project if you want to come and be involved.
Is it Gavi?
not different projects. Yeah.
No, it's not. It's not COVID. It's routine immunisation for children.
I'm absolutely interested if you ask me to join.
Speak to Dr. Maineni.
Yeah.
She's in charge.
Yeah, of course, because Mbak Wahyu is also one of our team especially in the pro. Yeah. Okay. So yeah, any other question, or maybe from the other participant, maybe from Zoom meeting or from Is there any question?
Oh, there are people online.
Yeah.
Oh.
Yeah. There is online.
Oh.
Bu Santi. Yeah.
Thank you, Prof. Julie and also Prof. Margie. One of the issue of the vaccine hesitancy, it's multiple injection. So I think how to administer the rotavirus with the oral, it's quite reduce the afraid of the mother, and how to what the possibility if there is any possibility for a combine between the OPV and also the rotavirus. I don't know, because it's my thing. It will reduce the incompleteness of the vaccination. So is it possible or not? That's the first, and
I suppose it's a question to Biopharma, and whether they can put it both in the same vial. There'll be enough room in the vial. I think the intention is that OPV will be rolled out, and replaced with IPV. So hopefully this will be a temporary issue, and IPV will be another injection unless it's NOPV. But anyway, so the I think physically it's possible, but I think probably future-proofing it won't be necessary, because you'll have an IPV instead of OPV. You'll only be left with one oral vaccine.
Because the multiple injection is also the issue, because some of the mothers, it's afraid if the child will be will have a lot of adverse effect for the multiple injection. So they try the okay, I will give my child a vaccine, but now for one injection and the other day for the next injection. But
So that's a very common question in Australia as well, and in most regions, and that comes back to the vaccine communication and the training of the healthcare provider, because you can answer that question for the parent and you can convince them that actually no, having multiple vaccines at once doesn't overwhelm the immune system, the child can respond, it is safe. If you split all those vaccines into individual vaccines, think of all the extra vaccine ingredients the child will get. So there's a way of communicating why having multiple vaccines at once is safe and it's good for the baby, but it's part of the training that we need to give the healthcare providers. So rather than spending a lot of money on combining OPV and RV3BB, we actually explain, no, it's absolutely fine to give them separately, and these are the reasons why. But the healthcare providers struggle with that. They don't know how to do that, and so very often the mother won't accept, say, more than one vaccine. So I think that's why it always comes back to this capacity building, how to
it's very related. The problem is not the mother, but the health provider itself. So before we convince from the mother, So we have to confident that the
Correct.
multiple injection is very safe and also effective and reduce the trauma of the
Yep.
children, because one shot or two shot, the trauma is only one. It's better than they have to go many times.
Exactly.
Yeah.
And that's one of the common role plays that we do. So we get the people who attend our training to actually practice that one, because it comes up every time. So it's a key question to answer for mothers. Yeah.
Yeah, because Indonesia now is a struggle how to improve the confidence that the multiple injection is very safe and
Yes.
also effective, and
Yes.
puts not only for improve the coverage. Yeah, and the more important is health provider. So we many time we do from the not workshop, but some workshop already done, but still hard work to increase the confidence of the health provider. And Yogyakarta, because we have multiple injections since maybe 10 or 15 years ago, because we have Pentabio and IPV in the same time. So Yogyakarta is very the acceptability is very high compared to
Yeah.
Thank you.
Thank you.
Yeah.
Thank you, Dr. May.
Any question? We still okay. How many times we still have? 10 minutes. Okay, it's very interesting. So maybe we have to expand. Okay.
Thank you so much for the opportunity, and thanks for your presentation, because it's really interesting. And actually we have a project related with the strategic communication, but it's focused on the vaccine COVID-19. So it's like really similar with what you said before, and what we explore about the vaccine hesitancy, and after that the relation between the community leader and also the religious leader. It will be like really effective way to communicate with the person, especially who do not really believe with the vaccine COVID-19. And we just have the project, the strategic communication through the Gotong Royong, and also for the protector schema. So it's just like related with the concept of the vaccine effective communication to the person who have a target to the get vaccine COVID-19. And both of vaccine COVID-19, maybe just like little bit outside with this vaccine, but I wanna ask you, especially in Indonesia, the government have the routine program in 2024 for the vaccine COVID-19, and it's specific on the elderly, comorbid with the obesity, and also pregnant women, and also people who have immunocompromised. So it's just like really high risk to get the vaccine COVID-19. And it's already in the Ministry of Health policy. My question is how to get the people with those priority who have like specific health issue, and they also do not really believe with the vaccine COVID-19, because it's like still worriness about, it's like really short time to produce vaccine COVID-19, and the adverse effect it's already high in the several population in Indonesia also. And how to the government achieve for the routine program to become a success program, especially for the priority group. Yeah.
Well, it's a really good question, and I think most countries are grappling with that now. Most ATAGIs are recommending COVID boosters for high-risk people. So and there are new strain-specific vaccines coming down the pipeline. So the next one cab off the rank is the XBB specific vaccine, which will become available early next year in many countries. So you're right, it is for high-risk people. And again, it comes back to the communication with the healthcare provider predominantly to explain why they're at high risk, why they need presumably a booster, hopefully not their first primary doses or at least their first booster vaccine. So, you know, we hope most people have had at least 3 doses, adults, by now, but maybe not. I'm not sure of the data actually around COVID vaccination for adults. But so it comes back again to giving the providers the knowledge and the skills to explain to people why they need the vaccine. The safety issue around the COVID vaccines, again, you know, yes, the vaccine development timeline was shorter, but none of the steps in the vaccine development was skipped. It still followed phase 1, 2, 3, and then implementation into the community. The reason it was 9 months or 12 months as opposed to 10 or 15 years was because of the huge global investment in the COVID vaccines, the fact that many manufacturers actually started the next phase before the previous one was finished because of the urgency and the need, the political will and so on. So there's lots of reasons, but in fact the same phases of vaccine development were still followed and they were shown to be safe. They needed the same robustness in safety data and effectiveness data to be licensed. So again, it comes back to the person being able to explain that they're not less safe. And in fact, when you say there were lots of adverse events, it was the scrutiny on the adverse events. You know, never before have we had like a whole of population vaccine program as we have had in the pandemic. But in fact, the serious adverse events probably are not greater than other vaccines. It was more the scrutiny on them, you know. So the myocarditis is the main one, you know, for young people with the mRNA vaccine. So again, it comes back to the providers and the government to be able to communicate this information. It's really critical. And what I was talking about in my talk was, how do you do that? Do you do that on a broad public communication level? You have to do some of it that way. But the most effective way is the interpersonal grassroots communication. And you mentioned the religious leaders. So they, and you know, with the rotavirus vaccine and the halal issue, you know, religious leaders, particularly in Indonesia, are very powerful, they're very trusted, and they've been identified by UNICEF, faith-based organisations, as a powerful agent of change to be able to communicate about vaccines. So we're going to be working with a huge number of faith-based organisations on this work so that they can go out into the community. But they need this knowledge too. The things I'm telling you now, they don't know this. They can't answer people's questions. So it's that combination of vaccine knowledge and communication skills. And it can't just be healthcare providers, because we've got healthcare workforce, you know, shortages. There are not enough healthcare workers. We need our religious leaders. We need our community leaders and our young people. We need our teachers. We need everybody with this knowledge. And that's really the aim of the sort of champions or the advocacy program, is to provide these skills broadly across the community. But you're right, it's really hard. That's why we need effective strategies and we need evidence, because at the moment there's all these programs run, but we need robust evidence, just like you have for a vaccine clinical trial. If you're going to influence policy and you're going to get governments to adopt these programs, we need really good impact data, and we need cost effectiveness data, which we're gathering as well.
Thank you so much for your explanation.
Prof. Yati, yeah.
Related to the vaccine acceptance, I would like to share with you how we're dealing with vaccine refusal due to the religions. It is the most hard problem. And we look for the real cause, and then we embrace the religious leaders in such way, so that instead of we who telling them, so the religious leaders who are telling them how important it is in related to the religions. And this is so successful, so that you should look for what is the main cause of the refusal. And then based on that, you don't need to do a player. The health care people don't need to be a main player. So that we should look for the real player, especially who come from their own, the community. This is the one that we successful in dealing with with the porcine refusal vaccine. Thank you.
Well, I think, you know, certain religious concerns can only be addressed by religious leaders. You know, they're not going to believe anyone else coming into their community. So, you know, people believe who they trust, their leaders in their community. So, the religious leaders, I think, are absolutely critical. But it's really complicated too, and it'll be interesting to see if they're willing to go through this training that we're going to be offering them. Apparently some of them are very interested, so we'll see.
Okay. Any question? Yeah, because I think we have limited time, so maybe before we close our very interesting lecture, I would like to summarize that rotavirus RV3-BB is very promising rotavirus because this is a neonatal dose, so there are some benefit of them prevented as early as possible before wild virus, yeah, and also it will increase coverage, and also it will decrease the side effect due to, for example, caution of intussusception, yeah, and also I learned that this vaccine also benefit from the diversity of microbiome, and that maybe especially from the alpha, yeah. We know that recently there is increased awareness of the healthy guts is very important for the healthy, not only the overall healthy, especially for the behavior of the children. Yeah, and it's very important to have the data of access and acceptability. Yeah, because we have to, for the intervention, we have to solve the real problem, whether this access or acceptability. And the effective communication is very important, the key information, key intervention, yeah. So I think we have to learn how to give effective communication, yeah. Okay, thank you very much. Applause for two speakers. Yeah. Terima kasih, saya kembalikan. Yeah.
Terima kasih Bu Mei. Yeah, thank you for the insightful presentation of the presenter. Now, before we closing this event, we would like to give souvenirs for the speakers. Yes, we would like to ask Prof. Yati to give souvenir to Prof. Julie. Yes.
This is a very special day. Thank you.
Thank you. Take picture first, and then we would like to ask Bu Mei to give souvenirs to Miss Margie, Prof. Margie. Yeah, we give applause again. Yeah. Okay, after this we would like to have photo session first with our speaker and the presenter, Prof. Yes.
I'm too tall.
I've got a couple of photos of me going down one step.
Oh yeah, I remember.
It's okay, we can stand together.
Okay. Yeah, 3, 2, 1. And then freestyle perhaps. Okay,
RV3, yes.
okay, perhaps after this we can have the audience to take picture with all the speakers.
Yeah, right.
We all did that in the Bali photo.
Ibu boleh foto bersama pesertanya. Please come. Oh, okay. Okay. Photographer, please take picture from.
With everyone.
Yes.
Oh, yes, please. Thank you.
How many?
before that, we would like to take picture for the participant in the Zoom. Perhaps you can open your cam. Yeah. Mohon buka kameranya bagi peserta yang ada di Zoom. Kita mau foto juga untuk dokumentasi. Ya. Oke, kita akan mulai menghitung untuk fotonya. 1, 2, 3, smile. Diulangi 1, 2, 3, smile. Baik. Ya, sudah selesai. Baik. Ya, dengan demikian berakhir sudah kegiatan kita pada siang hari ini. With the completion of the lecture, we hope that all of you can get benefit from the presentation. Let's join hands, build better human health, and let's promote the vaccination program. Before we end this session, please allow me to give one poem. Roses are red and apples are too. I had a great time having this lecture with you. Thank you. Emilia, thanking you all for all your attention and see you next time. Bye-bye.
Recording stopped.